I'm Professor Dr. Vivek Gupta on 17th of November 2025. I'm privileged to be a part of the London Valve meeting, and I'm standing with one of the stalwart of interventional cardiology, Dr. Professor Martin Leon. He's a chief course director, and of course, the first he started TCT conference, the largest conference of interventional cardiology of the world. I have to ask or talk to him regarding the innovation of transcatheter aortic valve implantation. In the next 2 minutes, he will be talking about how he came along with Alain Cribier, who was the father of TAVI, and how he made the company to start the first case, which was done in April 16, 2002. Martin, please.
Yes, thank you. Well, we're here at PCR London Valves, and it's a wonderful opportunity to celebrate what has been the historic revolution of TAVR in terms of its ability to transform the therapy of patients with severe AS. When we began this more than 25 years ago, we had no idea that this therapy could be available not just for the sickest of the sick patients who are not surgical candidates, but really as a routine procedure that is now being done in younger, low-risk, and everyday patients. So the dramatic evolution of TAVR over that period of time has been a consequence of our ability to be able to simplify the procedure, improve the technology, do many late-breaking clinical trials that demonstrate efficacy and safety in various patient populations, and then to teach the procedure to a large number of operators around the world that have been able to maintain good results.
I just wanted to know, when Edwards and Medtronic, they refused to complete the idea of transcatheter evolution, that was 1997 or 98, or when you made a company with Alain. So I just wanted to know just a few words about those times when you had to make a new company by the name of, what was the name of the company?
It was called PVT, Percutaneous Valve Technologies.
PVT, yes.
Yes. At that time it was a very radical idea to put in a transcatheter valve in patients. So there were not many people who supported us. So we had to do everything by ourselves. We had to demonstrate that we could do this first on the bench, then in animals, and then that we could begin to do it in patients. So yes, in the beginning I think there were many obstacles. There were significant complications. We had to evolve the therapy, but we were able to persist, and it shows that with innovation you have to be persistent, you have to be flexible, you have to continue to try to evolve your original invention, and then you have to demonstrate it in patients.
Dr. Cribier was telling me that he was planning the first case, that was April 2002. You had to give a small consent because there was email exchange, which I was saying. What happened actually? We have only 30 seconds to talk.
Yeah, well, it was a complex patient in cardiogenic shock, and this was a very radical case because there was no peripheral access. So we had to do this as a transseptal procedure. But Alain is a wonderful operator. He had a great team, and we chose this patient because he had no other options.
Thank you very much. Thank you very much.